Welcome, everyone. Bienvenidos a todos. Before we start, I just want to let you know that we have the service of simultaneous interpretation. For that, you can see in the controls at the lower bottom of your screen the globe that says interpretation, and you can choose the language that you want to do you prefer. Just to let you know that today all presentations are going to be in Spanish, so if you don't speak Spanish, you might want the interpretation into the English. Buenas a todos, bienvenidos. Quisiera
Once
recordar
again, good morning, everyone. I want to
la
remind everyone
sesión tiene
that this session
simultaneous
will be
interpretación de
interpreted
inglés, español. Hoy
to
todas
and
las
from
presentaciones
Spanish and
serán en
English. Today's
español. Si
presentations will
desea
all be in
escucharlos en
Spanish,
inglés,
so if you want to
en la
listen in
parte de
English,
abajo de su
please go
pantalla
to
puede ser
the
donde dice
bottom of your Zoom
presentación y puede
screen,
elegir la
click on the
lengua que
interpretation
desea
icon, the little
escuchar.
world, and then you can select
My
your
name is
language of
Liliana
preference.
Osorio. I'm the director of the Health Initiative of the Americas at the University of California, Berkeley. And I am so pleased that you are joining us today to the third session of the Summer Institute of Migration and Global Health. Bienvenidos a la tercera sesión de la decimoquinta
Welcome to the third session of our 15th Summer Institute on global migration and health. I'm Liliana Osorio. I'm the director of the Health Initiative of the Americas at UT Berkeley, and it's a pleasure to have you with us. I also want to remind you that after each presentation, we will have a space for questions and answers. For that, we ask that you once again go to your Zoom controls at the bottom of your screen to the Q&A icon. There you will be able to write your questions in either English or Spanish for our presenters today. If you have any other comments, greetings, technical issues, please let us know in the chat. Very well. It is a pleasure to begin with our third session today of the Summer Institute on Global Immigration and Health. We have a great lineup of speakers. We have a very special panel. Uh, just as a reminder, during the first session, we discussed the general overview on international migration, some numbers, and a bit about the current situation under COVID-19 and how it has impacted not only mobile populations when it comes to their health, but also other significant repercussions and impacts, for example, in collecting reliable data and in implementing actions uh, to serve these populations. During the second session, we looked at what's going on in the United States, and what legislative measures, or how legislative measures rather, have contributed to basically halting migration into the United States. We also heard about different health related activities being carried out by the US CDC, the Center for Disease Control and Prevention, when it comes to migrants and refugees in the United States. And we also heard about the specific impact that the pandemic has had on migrant populations within the state of California. Today, we will move to what's going on in Central America, and more specifically in Mexico and and in El Salvador in Central America. From El Salvador, we have a very special presentation on returned migrants in El Salvador. So let's get started. Our first presenter today is Dr. Yetza Bojorquez Chapela, who is a researcher at the Tijuana, Mexico think tank COLAF, Colegio de la Frontera Norte, and she's also in charge of immigration surveys on both of Mexico's borders, which are done regularly at the northern and southern border in Mexico for people that go through them. Her main areas of research is a relation between migration and health and social cultural, and practical implications on the health due to migration. Dr. Bojorquez has led several projects on m- mental health and returned migrants, access to health services for Central American migrants in Mexico, and the use of technology, such of new technology such as cell phones for deportee health, as well as other investigations. It is an honor for us to have Dr. Yetzabo Jorquez Chavela with us. Welcome, and please go ahead with your presentation. Thank you very much, Liliana. I want to thank you and the whole team that organizes this Summer Institute. It is also an honor and a privilege for me to be with you. I'm going to now share my screen. Very well. The topic for my presentation today will be the impact of COVID-19 on migrant populations in Mexico and how it is affected by health policies, but that affect not only health, of course, but that can have other related impacts. When we talk about migration and health, we always have to keep in mind that migration is a social phenomenon, and migration per se shouldn't be either a risk factor or a protection factor for people. What defines the conditions, rather, that people face prior to or after migration has to do with how our societies organized to either protect or not protect the health of migrant populations. So, health policies, of course, then play a key role. So, to the extent that we have policies that allow us to protect the health of migrants, the situation would be very different than if we don't have such policies. So, what I want to talk to you about today specifically is how health policies in Mexico, when it comes to migrants, interacted or is interacting now with the COVID-19 pandemic and how that leads to different conditions or vulnerabilities for these populations in Mexico. Well, during earlier sessions, you've already looked at some of this, uh, meaning that pandemic mitigation measures have impacted migration populations. So I would ask you the following questions. How have these mitigation measures impacted the migrant populations you work with? If we think of the effects of the pandemic, the first and most obvious that comes to mind is the risk of contracting COVID-19 and the serious complications that it might entail. But of course, there's a whole series of other risks and consequences that can also impact health. For example, when, as part of the response to the pandemic, health services are redirected to focus mostly on COVID 19 cases, that means that people have less access to other types of services, and that can have an impact on health. And when mitigation measures such as stay at home orders or restrictions are placed to avoid the spread, that can also impact people's health. So, all of these risks take on particular characteristics when it comes to migrant populations. And that's what we're going to talk about. And I'm an epidemiologist, so the idea of risk is at the core of our discipline of epidemiology. But what does risk mean? What do we understand as risk? In public health and epidemiology, we understand risk as the probability of suffering a condition, and we're usually referring to some negative condition, a disease or even death. And we define how likely it is for a person to face that situation, that issue. But we always do so, or in contrast to other populations. So when we talk about migrants as an at risk population or as people that face risk or could be at risk for something, we have to define who we are talking about and who we are comparing them to. So the first thing we need to define then is what are the types, to call them something, of migrants in Mexico. And these could be the main types of migrants in Mexico on screen. So we could be talking about people who return to Mexico, who are mainly coming from the United States. We know that there are millions people who are of Mexican ascent and who go back and forth between the US and Mexico and who return voluntarily to Mexico, whether they're coming to visit relatives or they decided to just come home or because they faced economic hardships or for family reasons. But for one reason or another, they decided on their own to return to Mexico. These type this type of immigrants could be the least at risk in this kind of a situation because they normally have a series of networks and circumstances that enable their transnational movement. And so they allow them to re enter their communities, both in the US and Mexico, when they go back and forth. We also have Mexicans who are returned to Mexico involuntarily. We can call them deportees, even though that's not the appropriate term because there are different types of involuntary returns, but let's call them deportees. So these migrants and their families who sometimes come with them face different circumstances because this was an unplanned return. And so perhaps they don't have access to some of the resources that those who did plan their return have. Also, within Mexico, we have people who have been domestically displaced due to violence, sometimes due to um, natural disasters, have had to leave their place of origin and move elsewhere within Mexico. So this could be some sort of emergency or which leads to vulnerability. Now we have people who have who are foreigners who were born in a different country who reside in Mexico relatively permanently. And we also have people from other countries that arrive in Mexico to petition for asylum or as refugees or who are already refugees in Mexico. And we have other foreigners who are in Mexico because they have the intention of petitioning for asylum in the United States. Many of them now have to wait in Mexico's northern border states while they await for their asylum petition to move forward in the United States. And we also have people from other countries who are in transit through Mexico on their way to the US. So these lead to different types of conditions and thus risks. And for each of these populations, there are also different types of risk. The risk of contracting COVID 19, of complications from COVID 19, but we also have social risks and psychosocial risks, which are impacts on their well being, their mental health in relation to the situation they're living through. So we have to define what risk we are talking about and compare it to whom. And these are all situations that a health system needs to address. To give you an example, we have official data in Mexico about suspected and confirmed COVID 19 cases. And based on that data, we can describe things in radically different ways. As you can see here on the left, we see the press release that is published by Mexico's health department about migrants who have tested positive or who are suspected cases of COVID 19. And in this case, migrants are defined as anyone who is born abroad. And here we see the distribution of these people in our database. And as you can see, in first place, we have Honduras, but we have the US in second place. What this shows is that through this analysis, they are considering all of the different types of migrants as being the same, or several of them at least, because we have several people who were born in the United States, but they're part of that transnational network between the US and Mexico. They could be children of Mexican people who were born in the US and then their parents returned to Mexico and now they are in our country, or people who were children of Mexican parents who were born in the US and then returned as adults on their own to Mexico. And that is the type of US migrants most often present in Mexico, but the vulnerabilities will be very different from those of people from Honduras who are usually in transit through Mexico who want to get to the United States and who are more vulnerable. Now, on the right hand side, we have a study that we did with some colleagues with the same database, but on a different date. So the global numbers are different as well. But we considered migrants those who are most vulnerable. So people who are along Mexico's northern border and who are from the countries that most frequently go through the Mexico to petition for asylum in the United States. So Central and South American countries, from the Caribbean, and from certain African countries. So if we take this new definition of migrant at the time of this study, we could say between 813 or 197 per 100,000. And it also depends on how we define the characteristics of the people along Mexico's northern border. But I want to contrast the difference between 813 per 100,000, 197 per 100,000, or 4.15 per 100,000. So depending on how we define migrant, our assessments and forecasts would be very different. And that is key because this is how health decisions are made and health policies are implemented. And this would lead to very different kinds of actions depending on how we define them. So, again, something that should be noted during this pandemic, and it always happens, but it's exacerbated by a pandemic, is that health measures have social consequences. So, limiting mobility and access to health for migrants are two of the social impacts, or two of the key social impacts of the pandemic restrictions. So, let's talk about these two restrictions and their impacts on health. So the first question would be, is it useful to close borders due to health reasons? The truth is, we don't know. It will probably take us years of studying this pandemic to find out what happened with countries who completely closed their borders, those who had partial closures, and those who kept them open, and so on. But it's different when we have porous and open borders, such as the ones and the Latin American countries versus scenarios where they have just one border. Greenland, for example, if you close the key airport, no one gets in or out. However, along the US Mexico border or along the Mexico Guatemala border, if you close ports of entry, you would still have hundreds, perhaps either even hundreds of thousands of people crossing through other routes. So closing down a border or shutting down a border will not or limit movement completely. So we don't know how effective or useful border closures are to stop the spread of the virus, but it does have significant impacts on migrants. We have longer waits at border territories where people are having to live under crowded conditions, which are not the most healthy conditions. There's also, of course, the uncertainty, which impacts mental and psychosocial health. And we are having, through these border closures, promotion perhaps not intended, but a very negative vision of migrants. Like migrants are the ones bringing the pandemic into a country. And in an analysis or a study that we did with our colleagues in Colombia, one of the things we asked was, when the land ports of entry were closed, the case in Colombia were arriving by air, mostly from Europe, eventually some from the US. But at that point, cases weren't coming into Colombia through Venezuela, for example, but they decided to close land ports of entry at a time when it wasn't really useful, perhaps, but had a lot of undesired outcomes. So that's something to be considered. Now, how do health systems respond to these situations? Well, when a health system responds to immigration or migratory phenomena, it is affected by different circumstances. For example, the immigration history in that country and their immigration policies will impact how they respond to these phenomena from the health system. It also has to do with how we understand what immigration is and who migrants are, and I'll talk more about that in a minute. Now, health policies impact this, of course, and as we can see, the health system can also have an impact on immigration policies. And n- domestic and international relations, which are also political, will impact it. So the health response, it's not just about what we traditionally think about as health and disease. It also has a lot of political, social, cultural background to it. In Mexico, in our study of public health policies, uh, prior to 2018, 2019, which was the most recent change in administration, all of the health policy documents in Mexico, when they spoke of migrants, they spoke about Mexicans and the US Mexico immigration circuit. So policies follow that. For example, the health booths at the consulates, the Leave Healthy, Come Back Healthy programs were aimed at protecting the health of Mexicans in the US and a little bit to protect returned Mexicans' health. So those were the policies. And there were a handful of considerations, almost none really, about other types of immigrants who were specifically Central Americans in transit. And what they had implemented for that is to allow them to have access to the public health insurance system in Mexico, which is called Seguro Popular, for 90 days. So they figured they're in transit. 90 days is about the time they'll spend in Mexico. And after that, they will have crossed into the US or return to their country. So we don't need to do anything else. Now, this wasn't the reality at the time. There were many people who needed healthcare access for longer periods of time. But this is just to illustrate how your vision of who a migrant is can affect the type of response. Now, what happened in 2018, 2019? Well, two things happened. We had a change of administration in Mexico, and we had something that was going on since before, but that became much more visible, much more in the media, which were the migrant caravans. So all of a sudden, when talking about migrants in the health arena, we were talking mostly about caravan members, mostly Central Americans, but also from other countries who were crossing through Mexico to petition for asylum in the United States and who were remaining at different places in Mexico. This is an image from Tijuana in situations that could be described as a humanitarian crisis. So these policies were the response to an emergency. So there wasn't a priority of enrolling people in this public health insurance, but rather a series of policies that had to do with epidemiological surveillance, emergency response, organizing shelters and camps. So the focus shifted from providing coverage in the medium to long term to a quick response to an emergency situation. So again, how we define the situation impacts how we respond to that situation. So what happened after that? What has been going on most recently with migrant related health policies in Mexico? Of course, the most significant thing that has happened is COVID-19, the pandemic. So what happens? Again, this reinforces the vision of an emergency disaster. So there is a bunch of epidemiological teams. So this deployment was our response to this caravan who was in transit rather in Mexico. And so its goal was to provide care to migrants who enter Mexico, monitor and reference of public health risks and first contact care or primary care, as an axis of humanitarian response. So again, it's not part of a permanent health policy for people who are going to be in Mexico. Now, in 2019, the Federal Health Act was changed, and that public insurance disappeared, Seguro Popular, and they're trying to transition to universal healthcare coverage for people at large. For people that don't have any other kind of insurance, the Ministry of Health will provide universal healthcare free of cost, again, to the people at large. However, this law, to date, from the end of 2019 to now, still has a clause that says that in order to receive such services, you need to be present within Mexico and present um, an acceptable ID. And these are difficult to obtain for migrants, and particularly for in transit migrants. So, the asylum petitioners, refugee petitioners, so people who are not legal residents or citizens in Mexico, as the law is drafted today, could not access this free healthcare coverage. There are some exceptions for ERs and so on. But as far as healthcare coverage, they are excluded. Now, they are working on second legislation, an amendment that is taking this into account. And we know that they're going to try to implement measures to include migrants. However, that is not in effect yet. So, right now, this places these migrants in a sort of limbo where they don't have clear coverage, but there's also no prohibition of providing them care. And this has led to a series of situations that are resolved when they arise. Perhaps some of you who are listening have been involved with specific cases and you try to resolve them. In some health jurisdictions within Mexico, they do it one way, in others, they do it a different way. So this is something that will be provisional, but it's been provisional during at least the 6 months of the pandemic. Now, in May of this year, the Federal Health Agency in Mexico issued the Migrant Population Care Operation Plan due to COVID 19. And I want to highlight the date. The pandemic started in March. Mitigation measures were uh, originally started in March in Mexico, such as closing non-essential businesses, stay-at-home orders, etc. But it took almost 2 months for this operation plan to be implemented. And I want to highlight this because one of my arguments is that when you define public policies, when you implement public policies, it is under the perspective of the majority usually, but many times the minorities are the ones who are most vulnerable. And so they should always be included and thought about when designing public health policies, those quote unquote exceptions, which could be the most vulnerable people when it comes to health. So when we think about the migration phenomenon in Mexico, these people who are in transit, many of them from Central America and so on, when it comes to numbers, it's small in comparison to Mexicans who are in the US Mexico immigration circuit, but they are much more vulnerable. So, this operation plan was fairly complete as far as their lines of action and defined rather that the local health jurisdiction within their area of work, their local jurisdiction would have to implement actions to implement the plan. So we'll see how well that is actually done and so on. I am approaching the end of my presentation, but if I'm running over time, please let me know. Another thought that I think is very important to keep in mind is that public health has to follow ethics principles. And these ethics principles are different um, than other areas of medicine like psychology or clinical care that don't have to take that into account as public health does. And these ethical principles need to be taken into account when defining policies in the case of COVID, of course, but in general, any public health policies that will impact or affect migrant populations. So, why or how does public health ethics differ from ethics in other areas of health? Because in public health, it needs to find a balance between the best interest of the population and the best interest of the individual, and how much you can limit the freedoms of the individual when that is necessary for the benefit of the population. Right now, we have a very clear example of the protests against any of the COVID-19 measures, people who don't want to use face masks or who want to challenge stay at home orders. So we have this difficult situation between population and individual, where it is generally accepted that it is allowable to limit the individual to a certain extent when the actions of the individual can endanger the population. Thus, the restrictions, the stay at home orders, the mandatory quarantine in some cases, and so on. But what risks do those policies also entail? So we need to find a balance between those risks and those benefits, both for the population and for the individual, and for different types of populations and different types of individuals. So if we implement a measure that places particular groups at risk, in this case, migrants, we are putting a disproportionate burden rather on these populations, and risks and burden needs to be distributed fairly amongst the different populations, which is one of the principles of bioethics and ethics in public health and so on. So we have to take into account that there are certain groups could be particularly impacted by a public health measure. So if we looked at public health measures just in a lab without taking into account social impacts, they may seem appropriate to have desirable effects, such as slowing the spread of a virus, which is important. There's no doubt. But public health measures can also have unintended consequences that we have to take into account when the policy is designed. And in order to take those unintended consequences into account, we need to think about how the policies will impact different populations. In the case of migrants, particularly migrants who are in transit, and so we're talking about, again, people who are refugees, people who are petitioning for asylum, people who are in the country undocumented, who don't have those networks. And so, and they they don't have public health policies that will enable them to face situations such as the pandemic without undue risk or disproportionate risk. Oh, when we're talking about the public health ethics principles, the first people we have to think of is the most vulnerable populations.
Doctora
And that was my
Bojorquez,
last slide. Thank you
muchísimas
very
gracias
much.
por esa
Dr. Bojorquez, thank you
presentación
so
magnífica. De
much
verdad que
for
me
your
parece muy,
great
muy
presentation.
interesante y también
It is very
el punto
interesting
de
to
vista
me
de cómo se ha
from the
cambiado
perspective of
la
how
migración de México, ¿no? Yo
migration
también casi 20 años
in
trabajando
Mexico,
acá en
or the
Guatemala
definition of migration
y
in
hemos
Mexico is
tenido
understood. I
el
have
agrado
spent many
de
years
hacer
working on
capacitaciones
US
al
Mexico
cliente de los mexicanos en el
immigration.
exterior
And it
y
has changed
ahora
from being just a
el país
sending
de
country.
destino, ¿no?
It
Entonces,
is now
también
also a
escuchar
destination
el discurso
a- and a
de,
transit
que
country.
ha sido muy fuerte de parte de México,
And Mexico's
acercando
very
también a
strong
ustedes también y
discourse
ayudando
towards
a los
the
mexicanos
US
en el
and
exterior.
helping
Ellos estaban
Mexican migrants in the United
darles cuenta
States
también
from
que
Mexico as
ellos en la
government.
posición de que
Now
tienen que respetar y
they
ayudar
also
a los
have to
migrantes
be in the position of
de otros
respecting and
países,
helping
especialmente de
migrants
Centroamérica,
from
pero
other
también
countries, mainly from
en
Central
México.
America, uh,
Quería
who are in
recordarle a
Mexico.
todos
I wanted to
que pueden
remind everyone
escribir sus
that you
preguntas
can
en la sección de Q&A,
write any questions you may
hacer
have
preguntas
in the
preguntas
Q&A
que tenga hacia la
section
doctora Bojorquez.
by clicking on the Q&A
Quisiera hacerle
action
algunas
on your Zoom
preguntas a
control.
la
So if you have
doctora.
questions for Dr. Bojorquez,
Usted
I
mencionó
would like
que
to
en
start with a question,
marzo
Dr.
se
Bojorquez. You mentioned
creó
that an
una
operation plan was
organización
created in May
gracias a la protección de los
aimed
migrantes.
at
¿Nos
protecting
podría hablar un poquito más en
migrant
términos
health.
prácticos?
Could you tell us a bit more in practical terms. Let's say a migrant who is in transit through Mexico. What services, health services, could they have access to? Right now, under COVID 19, do they have access to testing? If they require hospitalization, what happens? Well, when it comes specifically to COVID 19 and getting screenings and hospitalizations, the policy is to make it available to everyone, anyone who has symptoms. And well, as you may know, Mexico's policy is to test only a small sample of people who have COVID 19 symptoms. The epidemiology agency has case definition, but they only test a percentage of people with symptoms and a percentage of people who are hospitalized. So not everyone who has COVID 19 like symptoms are tested, but that is done both for citizens and migrants. So that's across the board. Now, in shelters or places where we have a concentration of migrants, the health authorities have been following up very closely, and they've been sending teams out there and doing screening when necessary to contain outbreaks in these shelters where we have a large number of people together. So that has been the policy when it comes to COVID 19. Now, the thing is, something that the pandemic has sort of hidden for the last few months is all of the rest of the health conditions that require care. And it's even more important to provide services for migrants, for example, for pregnant mothers or things that have to do with accidents or uh, workplace incidents or uh, violence or chronic illnesses. That has sort of fallen by the wayside for everyone, for the whole population. But these are health areas where the migrant population has had less access than the Mexican people, in part because legislation, regulations did not enable for uh, providing care, which with again just the 90 days of health insurance coverage through the um, public insurance. But now that there's supposed to be universal coverage, in theory, they would have access to all services, but we still don't know what services will be provided under that legislation. And there's still the issue of having proper ID. So right now, it's still not clear. So again, as cases arise of being resolved, so we could ask people in different cities, what are you doing in this city? And they'll tell you a different story than in some other city because the legislation hasn't been passed. So we don't know clearly how migrants will be covered under universal healthcare coverage. So hopefully it will be passed soon and that they are properly included. Now we have a series of questions in the Q&A. One is from Raquel who asks, what is the positive percentage in shelters in border city and in the migrant population in border cities like Tijuana, Mexicali, and Nuevo Laredo? I think anyone who has the answer to that question could win, maybe not the Nobel Prize, but some sort of big prize. I don't know, the jackpot. We don't have the data in order to answer that question. And in my opinion, the fact that we don't have that data just goes to show that migrants are not covered properly by our healthcare system. Because if the system cannot provide data about a particular group, a particular population, then it could never respond to their needs. I was showing you that press release, which is an estimation, but we truly don't know. At least openly, we don't know how many of those cases happened at shelters. And of those, how many at shelters in Mexico's northern border states. Our study was a first attempt at that, but we would need, but we, but again, as just it could be anywhere between 80 to 800 cases per 100,000. So it's difficult to get that data. Now, anecdotally, and from what we have heard in the media and so on, I should highlight that we have had few cases and few outbreaks in shelters compared to the risk we were expecting. And I think that has a lot to do with the measures that the shelters themselves have implemented to protect the people at their shelters. So I could say something very general like less than what I expected, but I think that it's a very serious issue that we can't provide accurate data. Oh, and speaking of data, during previous sessions, a lot was said about how difficult it was to collect data during this pandemic, and how, for example, in the United States, uh, no data is collected when it comes to nationality of or country of origin in surveys. Is that the case in Mexico too, or do they actually have a space to collect data for country of origin, language, and so on? The publicly available database has a country of birth as a variable, as a question. That is our best approximation. And another survey question is migrant. But that migrant variable contains no data in 99.5% of cases. So we can try and do studies. In fact, the Federal Public Health Agency table has a number of migrants. And the other thing we have is country of birth. But country of birth just means, as you know, that they were actually born in that country, but they could have been living in Mexico for 67 years. And it's not the same thing of as someone who has been in the country for a few months. So Caroline asks whether the surveys that are being done on Mexico's northern border are undergoing methodological changes uh, in order to collect information about migrant people during the pandemic. Well, the one I am in charge of, the Northern Border Immigration Survey, has undergone changes. Well, first we had to halt it. We weren't able to do it between March and mid July, really. So that was an issue because we had no data for that space, but we couldn't expose either the surveyors or the participants to the risk it would entail. Now we have restarted, of course, with proper protective measures such as social distancing, constant hand washing, face masks, and so on. But what we have seen is that people are less willing to answer questions. No one wants to be, standing up relatively near another person for 30 minutes to answer questions, and that's understandable. So that has made it difficult to do face-to-face interviews now. INEGI, Mexico's Institute of the Census and Statistics, has been doing over the phone interviews to replace those face-to-face interviews because they are difficult. But of course, when you do a phone interview, you exclude anyone who doesn't have a phone, and the language that you do the interview in can also have an impact. Okay, well, Dr. Bojorquez, thank you very much. Um, if you would be kind enough to stay until the end, if we have time, then we will have a second round of questions for Dr. Bojorquez at the end. However, for now, we need to move on to our next presentation and presenters. We have two speakers. First, we have Cesar Rios, who is the founder of the Salvatorian Migrant Institute, or INSAMI for its initials in Spanish, the first organization for, and also for the founder of the first deportee organization called Remittances in El Salvador. With Dr. G.C. Mosa, they created the first healthcare clinic for returnees. And Dr. Sami is also the technical director for the Regional Association of NGOs. And he is also the NGO representative at the Salvatorian Migration Council. He's a member of the board of the Health and Migration Board called INCOSAMI for its initials in Spanish, and the NGO representative at the advisory board for the Central American Health Integration System. Mr. Rios has written for newspaper articles as well. And our second speaker is Dr. G.C. Mosa Garcia, who is a founder of private clinics, including the Returnee Healthcare Clinic in El Salvador, where he currently serves as medical director, developing the psychosocial and medical care department for returnees. The doctor is a graduate of the National University of El Salvador and Nueva Universidad del Salvador. He is an advisor on the immigration board pro returned migrants, and he is also a member of the board for the National Network of Returned Entrepreneurs. It is a pleasure to have you with us this morning, and please, the floor is yours. You may start your presentation. Welcome. Thank you so much. It is a huge pleasure to be with you this morning. And my warmest regards to Dr. Bojorquez, who basically did the whole introduction of what we were going to talk about today. She gave us a very good overview of immigration into region. And Central America, like Mexico, has a very large number of migrants. We are here together with Dr. Hisim will do a brief introduction, and he will then add details as to how we have been dealing with this health emergency since its outset. So, as an introduction, I can note that this health emergency brought to light a series of significant topics that need to be taken into account when designing public policies. Now, something Dr. Bojorquez said um, seemed noteworthy to me, that when she talked about policies that will limit individual mobility to protect the population at large, but deportations from the US to El Salvador never stopped, or um, deportations from Mexico to El Salvador. And so certain actions had to be taken that limited those returned individuals to protect the population at large. We realized that there was a lack of public policies, and there was also a lack of budgets to protect migrant health, and also a lack of budget to respond to emergencies. When our returnee clinic moved into an emergency situation uh, to care for these returned migrants, it was because this population couldn't get care elsewhere. We are always highlighting that in the middle of this pandemic, all eyes, all actions, and all resources focused directly on the population that were being involuntarily returned, who were being, in other words, deported from Mexico or from the United States, and thus forced to return to El Salvador. So, national budgets, international support, international entities focused on those individuals during the emergency. And that led to a unique situation because deportees who had arrived prior to the pandemic and who were highly vulnerable during some of the most difficult moments of this emergency had their situation worsened. In other words, they became more vulnerable. They had no income, they had no work, and this made things difficult for them. But since all of the policies and all actions were focusing on the COVID-19 emergency, it made things much more difficult and it made them more vulnerable. And that is where we came in. Because, for example, migrants were being returned through the land ports of entry and through airports, and they were placed under strict controls by immigration authorities. And, and this included some of the health authorities. But it ignored the rest of the needs of our migrant population aside from those returnees. So, our office, the National Salvatorian Migrant Institute, which is a non government organization, started receiving a series of phone calls from people who had been returned and who felt abandoned. These were our migrants who were returned, but who had arrived prior to the pandemic, but who suffered from illnesses that required medication from the national health system. But since the national health system had turned its eyes to the emergency exclusively, these people had no longer had access rather to their medications. The healthcare system could no longer provide them. And this is where our institution came in during that emergency, when we were answering phone calls, when people called our returnee clinic and said, look, I need this medication and I can no longer get it from the healthcare system. What do I do? And so our returnee healthcare clinic started caring for those patients who has not been able to go back to normal activities because, again, the whole national healthcare system is focused solely on the COVID-19 pandemic. So we need to redesign all of our network support and how we work with hospitals. Something I should note is uh, what we know in El Salvador as the return cycle. People who are returned involuntarily to El Salvador, who are deported back to El Salvador. So the cycle starts when a person, a man or a woman, is separated from their family, from his or her family, in the United States, perhaps taken from his or her home, leaving behind children, home, all of their assets, and is taken to an immigration detention center in the United States. And at that detention center, they spent a lot of time with other migrants from many different countries. So that person who was separated from their family, who was detained for deportation, perhaps was very disciplined in their home as far as protecting their health. But once they're taken to that detention center, then they are exposed to the spread of the virus. And after remaining for 2, 3 months at that detention center prior to their deportation, then they're put on a plane with other migrants from that they gather from different places in the United States, and then they travel on that plane and arrive to our country, El Salvador, in a more vulnerable state than before. And this leads to one of the first consequences. Guatemala was the first to raise their voice in saying that those planes from the US with um, deportees had a lot of COVID 19 positive cases. Then Honduras said so, then Haiti said so. And that's when there was that international response demanding that the US screen these people before deporting them. And that took a lot of time. It took perhaps a month before the United States agreed to increase the number of tests for deportees. It, sh- it should also be noted that Guatemala, Honduras, Haiti has said that COVID 19 positive people have been returned, but in El Salvador, there are no official numbers to let anyone know that some of these deported individuals were COVID 19 positive. As an NGO, we weren't granted access, we weren't allowed access to um, to them or to the information. We had to depend on the official federal reports. However, in our practice of uh, we were serving these returned migrants that weren't being provided access in the healthcare system. Now I will act Dr. Mosa to continue with the presentation as far as what was done specifically at the clinic. Good morning. Once again, I am Dr. Kisi Mosa from the, I send the best regards from our deportee healthcare clinic. And thank you for allowing us to be part of this third session of the 15th Summer Institute on global migration and health. So I'm going to give you the example of what we're doing at our clinic in El Salvador. Next, please. This is the contents of our presentation. First, we'll give you an overview about our clinic. Then we'll talk about some of the deficiencies in the Salvadoran health system, the most frequent pathologies among deported migrants, and conclusions. So, an overview of our clinic. The clinic opened its doors to provide or cover the healthcare needs of deported migrants in 2017, based on the physical and mental affectations seen by Naceres. In El Salvador, Naceres is the national network of returned entrepreneurs in El Salvador. And so they have different institutions that are part of it, such as Doctors Without Borders that participate, and domestic NGOs, even the Ministry of Health and public healthcare workers, doctors within this organization. And that is how our clinic came to be. And it exists within the facilities of the Salvatorian Migrant Institute. Next, please. Beginning in February of 2017, our clinic, CLEAR for its initials in Spanish, has been a reference clinic for the returned population in order for them to be able to re-enter the national health system, since we didn't have anything in place for these returned migrants. It should be highlighted that we've been in operation for 3 years, and from 2017 to date, next please, we have seen 1,571 patients. However, it should also be noted that from 2017 to date, 92,870 Salvatorians have been returned. So 1,571 people is only 0.59% of this return population that we have been able to serve as a specialty clinic. Next, please. Again, our clinic has served a total of 1,571 return patients. Of them, 40% were female, 59% were male, and 1% were from the LGBTI population. Now, we have no political ties and we serve all people. And I should also note that all of our staff works as volunteers and very enthusiastically and with a lot of dedication. Next, please. Now, deficiencies in the Salvatorian healthcare system. Next. The public health status in El Salvador is no different than other Latin American, African, and certain Asian countries. We share a lot of factors with these countries, such as our budget. We have minimal budgets and coverage, lack of technology, which is something else we share with these countries. Currently, $750 million will be invested in healthcare for the 7 million people that we have in Salvador, and that is not even 5% of our GDP. There are developed countries that invest up to 14% of their GDP in health, which shows how short our budget falls. And it should also be noted that our Constitution says that that providing healthcare is an obligation of the state. So, and we don't have enough doctors, facilities, or medications to cover some of our return patients. Now, during the pandemic, the healthcare crisis for our patients and our return population became even worse. Again, all eyes turned to COVID-19. And so the few people that had access to healthcare then are currently receiving no care, which led to an initiative at the outset of the pandemic. We never closed our clinic doors. We continued to work, and in partnership with other organizations, we created CARES, which is the Center for Deportee Care, and we even created a sort of food banks, and we had medical campaigns to provide medication to patients out in the streets even. And this initiative was made possible thanks to support from partner organizations of CARES. Next, please. So by 2020, as I had mentioned, the estimated investment in the healthcare sector is $755 million. So, and again, it doesn't even reach 5% of our GDP. Now, most frequent pathologies amongst our deported migrant population. So we have included the top 10 healthcare issues faced by returned migrants. Diabetes at 28.81%. Diagnosing patients is key. Many patients were unaware of being diabetic until they returned to El Salvador and came to our clinic. However, there are patients who need insulin, but they're not managed with insulin in our national healthcare system because not all of the health clinics have insulin available. Only a handful can prescribe it. Only endocrinologists can prescribe insulin. But in El Salvador, to have an appointment in the public healthcare system with an endocrinologist, it would take at least 2 years for a patient because first they have to go to a primary care physician who provides palliative care, and then they refer the patient whenever they decide it's necessary. But again, it, it will take, even after that, 6 months to a year to be able to see an endocrinologist. So these patients will become more complicated, and the disease can progress in the meantime. Now, high blood pressure is in second place at 20.34% of patients having high blood pressure. And again, many of our patients receive some treatment regimens, but they're low quality. Some need to be assessed by cardiologists, they need lab tests, and a lot of that is not done because these patients usually end up going to health clinics where the doctors are not empowered to provide better medications or medications needed for their pathology. Depression. Now, depression is something that receives little treatment in El Salvador. Many people say that it's not even taken seriously as a health condition. And we've had people who are bipolar, who are manic depressives, and maybe 10 of them are receiving care in the healthcare system out of the people we see. And and all they get is something like carbamazepine or some other um, or a low quality antidepressant, colitis, which is at 6.78%, which also has to do with poor eating habits and depression that is mismanaged. Some of these patients require colonoscopies. And from our clinic, we haven't been able to get any of our patients into a colonoscopy. Now, 3.39% of our patients suffer gastritis. Now, in addition to these patients needing to see a gastroenterologist, and most of the time what they're given is basically an antacid, and maybe even need proton bomb blockers. And they're not prescribed, one, because they're not covered under the basic medication list. And second, because even if they are, they would need to be prescribed by a gastroenterologist. Now, 1.69% also are obese, which also need to see a specialist, and these go untreated. In fact, there is no morbid obesity program. And these are patients that would require bariatric surgery. And since there isn't a bariatric surgery program, so there's little treatment of obesity in our country. Now, of all of our May patients um, who have prostatic hypertrophy, are is not usually tested. And so the cause for prostatic hypertrophy is managed in clinic, but not through actual tests. Cervical compression, 6.78%. And this type of pathology is usually due to injuries suffered while they were abroad, but since they didn't have medical insurance in that foreign country, they basically depended on self-medication for pain, and they haven't actually been cared for through, MRIs and then neurosurgery if required, and so on. Now, bronchitis at 10.17%. Acute respiratory infections is the second leading cause of death in our country. And this group usually also includes patients with asthma who need inhalers, and we don't have access to allergists and other specialists who can properly manage their condition. We have 1.69 with orthopedic conditions or disorders. Again, a lot of times due to lack of treatment, people who had um, broken bones, who had sprains that went untreated and then got complicated. So, chronic diseases, or there's little interest in chronic diseases in our country. So, as a conclusion, next, please. Investment in the health and migration. The countries that are deporting people to El Salvador, 90% of them from the US, we should demand direct investment by the US to improve the health of our deported migrants. Our brothers and sisters left El Salvador young and healthy, and then they're returned older and sick. And we as a society need to also care for them because these were people that were creating wealth for both countries while they were abroad. Up to 19% of our GDP is represented by remittances. So we need to return that favor. Now we need specific actions to address the migration phenomenon. NGOs and agencies all talk about migration and human suffering, but that isn't enough. We need specific, concrete actions created together so that access to healthcare and continuity of treatment can become a reality. We need to practice an integrated health management model. Again, we are the first clinic in the Northern Triangle that cares for migrants, that is providing medical, psychological, and psychological care for returned migrants. We also need early diagnostic and treatment of these diseases. An early diagnosis and treatment improves results for migrants. Many of these migrants did not have access to a healthcare while they were abroad because of their immigration status. And as a result, their health has deteriorated 100%. Less than 0.05% of the patients that come see us are healthy. All of them have some sort of pathology, whether physical or emotional impacts. We need to follow the WHO's mandate that states that healthcare includes the physical, mental, and social well being of an individual. And again, this has been exacerbated by this pandemic. It has made more visible how much we lack in our healthcare system. Thank you. Thank you so much, Mr. Cesar Rios and Dr. Mosa, for such a wonderful presentation. I am sincerely grateful for the wonderful work that you do because I think that out of the migrant population, people who are returned are the most vulnerable, particularly when they return to their country not voluntarily, but as a result of being deported. So it is said that they become migrants in their own country, and it makes things even more difficult. I still remember when I first met Cesar Rios at a meeting in Costa Rica some years ago, and I was truly impacted by his presentation, where he also talked about the issue of mental health of returned migrants and w- the activities that you have implemented at your clinic so that you can create a peer support network because only a returned migrant can understand the situation of another. And I think that's very special. So I would like to ask, how is your clinic funded?
Eh, Muy bien. Mira, hemos nosotros
Um,
mucho
Look, we
manifestaciones
were
de emergencia
very
para
surprised
atender a la población.
by how
Recibimos
many people
recursos
came
para
to us during this
comprar
pandemic
medicamentos,
so
para
that we could provide other care
para
for the
hacer
population.
cuidados
We
y
received
demás.
funds to buy
Siempre hay
medication
disponibilidad y
for
también
these
este,
returned migrants who wanted
recibimos
to
fondos para dar
um,
víveres y
have
comida
continuity of
de
care.
emergencia.
We were provided funding
Eh,
to for
y así fuimos
food
recibiendo
so that we could
alianzas con
provide
diversas
food and
instituciones
to
que
these
querían
migrants, and
ayudar,
we
¿verdad?
started partnering with
Quiero
different
resaltar
institutions that were willing
tres
to help.
países
Now,
porque vimos una manifestación
since
espontánea para
you
ayudar.
asked the question, I do want to note that we
Por
saw
ejemplo,
uh,
nos daban
people coming
medicamentos,
to us on their own because of this emergency,
nos daban
providing
más
PPE,
para
providing
nutrición,
medication,
pero
again, funding for food.
nadie piensa en la
However,
actividad operativa. O sea,
um,
nadie de la
no
cooperación
one
dice,
thinks
vamos a
about
darle
the
para sus
cost of our
operaciones,
operation.
para
So
que
nobody thought,
puedan
here's some money so
vivir.
that you
La
can work
cooperativa
better, so that you
se creó
can
para ayudar
install
ya
phone lines to
a los médicos,
cover the
a las
payment for
administradoras, nada,
psychologists,
eso fue
doctors,
para que la
administration.
cooperación. Yo siempre
That
digo esto,
sort of
la cooperación
falls
es
by
una
the
inversión,
wayside. And that's something I always
que hay una parte operativa
say
para hacer
to international donors,
esto
particularly, that there is an
apenas
operation cost.
en algunos
And we
países
as
no se
NGOs
reconoce la labor de médicos ni de
um,
psicólogos
do this a lot of
no se
times as
reconoce
volunteers. And so the work of the doctor and the psychologist and the clinicians is not
y aquí
uh,
estamos, ¿no?
acknowledged
Creo
in
que
that sense as when it comes to funding.
ahora, una vez tenemos ya más controlada la emergencia, lo
But now
vamos
that this
a
pandemic
con una
is
cantidad
more under control,
adicionales
one of the
muy
good things is
importantes,
that we're going
muy
to have
importantes que
significant
fueron
interinstitutional
básicos para
partnerships
nosotros poder
with
comenzar
entities
con
such as
eh,
yours that
la
serve as
próxima
a
semana
vehicle where
tenemos
we can
programación.
talk about
La
what we
verdad que
do.
nos ha invitado
Next week, Congress has invited us
aspiramos
to
a
their
dar
legislative assembly, like you have,
referencia
so that
a lo
we
que
can
hicimos en esta emergencia.
tell
Y
the
ojalá
fathers
algún
of our
día
country what we have done
lo
during this
podamos hacer y
emergency.
ojalá después
And I've
tengamos
been
acceso a alguna
um,
presentación de la doctora
taking
Bojorquez
notes, and I hope that I'll have access to Dr. Bojorquez's presentation later, because we'd love to share some of that with our legislative assembly in El
que no
Salvador.
tienen presupuesto
First and
para
foremost,
la
that they need to
migración,
assign
el cual
budget
no hay.
for
Y por ejemplo, tenemos
immigration
el
and
Ministerio
health
de Trabajo tiene
together,
un
which we don't.
presupuesto
For
destinado
example, the Ministry
a
of
ayudar
Labor
realmente a la población
has a
migrar.
budget for the
Eh,
reintegration of
Tenemos
migrants into the
fondos
workforce.
del Ministerio de Relaciones
There is
Exteriores
funding
para
from
facilitar
Foreign
migraciones,
Affairs to
pero el Ministerio de
facilitate
Salud no
their
tiene
return to
presupuesto
work.
para
But the
insertar
health
el
department
sistema de
does
salud en
not
la
have
población.
budget
Entonces, esa
to
dependencia
reintegrate them into the
presupuestaria
national healthcare
empieza
system.
a trabajar
So that is a
el
gap
Ministerio de Salud
that
ya
we wanted to bring to light so that public policies can start being designed to resolve that. Yes, thank you. We have several questions from our participants. One says, what information do we have as far as the prevalence of TB, tuberculosis? amongst returned migrants? And do you do an active search of TB cases? And also, let's say a patient comes to you who was diagnosed with TB in the United States and was receiving treatment. Can you refer them, or do you have communication with those doctors in the US to talk about their treatment? But the question was mainly about the prevalence of TB. Well, unfortunately, as Dr. Bojorquez also stated, this is information we'd love to have. We'd love to know how many patients also have been returned who were COVID positive, but we don't have access to that data. That all, this is institutional information. There are no public reports regarding prevalence of TB amongst returned migrants. And when we suspect a patient uh, could be TB positive, we normally refer them to the healthcare system, to our third tier hospitals in this case, who are the ones that manage TB in our country. We also have a question uh, that says that given the information you shared, Dr. Mosa, about some of the conditions suffered by returned migrants, do you believe that people who stay in El Salvador, in spite of limited resources, could be healthier than those that migrate abroad and do sometimes very hazardous activities? So, so can they be healthier within our country? Is that your question? Yes. Well, usually the type of work people do can impact our health. And we have undoubtedly seen that people who were in the US lacked access to healthcare. Many of our patients come to us with high blood pressure rather, and diabetes, and they were unaware of that fact. They've returned to our country, and then uh, a handful of them, when uh, they collapse, for example, they were taken to some free clinic and they got some treatment. But when we diagnose, we refer them back into the national healthcare system. So we want to improve the health of our returned migrants. But our national healthcare system does not provide for that continuity of care. They don't have a system that accounts for these returned migrants. Now, you spoke about depression. Are there only other uh, frequently seen mental conditions or mental affectations amongst returned migrants, um, particularly during the pandemic? Well, we've seen a lot more attacks and anxiety during the pandemic. And even with people that we had already referred to the national healthcare system, um, uh, they are not getting their treatment. So stress and depression has become worse. We have some manic depressive and bipolar patients, like I said, and they are not being provided treatment, even with the medications that they used to be given, which weren't ideal, because again, they were basically given medication to prevent seizures or anti-seizure medications, but they're not providing proper care. And even that improper care has been stopped during the pandemic. Another question is there funding to support elderly returned patients? And how much access to information they have? Well, look, your question has to do with how to separate and identify the different types of returned migrants populations. Those are who are part of the immigration route, who are those who are deported from Mexico, those who are um, part of that catch and release system in the United States. Now, others who have been in the U.S. for less than 5 years, those who were released from prison and then immediately deported. And then we have people who have lived in the US for more than 20, 25 years and who have faced a deportation process end up being deported. The people that are caught during their immigration route in transit are usually younger people, under 25. However, those who actually work in the US, those who have worked in the US for more than 20 years, are 45 years of age or older on average. So, when less than a month ago, the United States declared that immigration at the US southern border with Mexico has decreased by 75%. And the Minister of Foreign Affairs in El Salvador says that 90% of these people are being returned to the US. It makes sense because the border was closed, but people were still being deported. So if people could no longer cross the border into the US, these many of them that were being deported now that the border has been closed are people who had been living in the US for many years. So these are people who are 45, 50 years of age or older who are being deported from the US, mostly. So to reintegrate someone who is over 50 into our workforce in El Salvador is difficult because of the discrimination that happens at that age. And at that age, usually they also have medical conditions. So the basic question, and something that I ask constantly, is if a person went to the United States and they worked for 25 years and they contributed to creating wealth in different productive sectors in the United States and helped to the development of wherever they lived in the United States and they gave the fruits of their labor and then suddenly they get deported after 25 years, who should guarantee that social safety net for the person? Who should be funding the protection of that person's health? The country where they left the fruits of all their labor, or their country of origin, who is now receiving them after they served that country? So these are the types of contradictions in that coming together of immigration and deportation, because this isn't solved through development efforts between the two countries. We need something specifically to address the health and healthcare of people who lived abroad for so many years, particularly in the United States. Now, when it comes to age groups, they also ask what kind of pathologies or issues have you seen or faced in children, particularly boys and girls who are unaccompanied minors and those who travel with their parents. Um, Again, we can't have access to that data, and we can't care for children because of the type of clinic we are. Pediatric clinics are the only ones that can care for children. But what we have seen anecdotally through what fathers and mothers tell us is also that fear and depression in some of these children who are returned from the United States. That's what I know. Um, if I told you any numbers, I'd be lying because we're not authorized to see children at our clinic. Now, one of our participants asks whether you think it would be possible to demand that a certain percentage of the money produced by migrants when they work abroad, particularly in the United States, could be used to cover their healthcare needs in their countries of origin.
Una pregunta muy interesante, muy de
Uh,
actualidad.
and in the US as well. A very
que podemos,
interesting question.
podría decir en nuestros países, principalmente en
Um,
Centroamérica,
in
en
our
México, en parte,
Central American
se ha
countries and in
comprometido
Mexico also
a
partly,
proyectar el desarrollo de su país
we
basado
project
en un
the
ingreso de
economic
divisas
growth of our countries
y no con un
based
ingreso
on remittances created
exportado.
abroad and not
De nuestros
necessarily
países
the production
se ha
machinery
enfocado
within our
mucho
countries.
y muy
It's
positivo
very
estar
comfortable
recibiendo en El Salvador
to
casi el
receive.
20%
In El Salvador,
de
it's
las
almost
migraciones.
20% of the GDP
¿Ya?
in
Gran
remittances.
parte, gran significado solidario. Y aparte de eso,
And it has a
pensar
huge
en
solidarity meaning.
utilizarlo para la seguridad
Uh,
social o para programas
so
sociales o
uh,
para
to think that it should be
demás.
destined
Esto
to
considero que sería
funding social programs or healthcare
no es lo
programs,
más saludable que puede
um,
haber para la familia. Hay
I don't
familias en El
think
Salvador
would be
que con
the best
300
thing
dólares
for families.
pueden
There are families in El
adquirir
Salvador that
un hogar
support
completo
three
y
kids and a
para los
full house on $300 a
familiares
month that is being
con
sent back. So they are funding
el virtual
their children's
también
education, health,
funciona.
clothing, food
Por
with those
primera vez,
resources.
familias pobres en nuestros
For the
países
first time in
tienen un
history, poor
ingreso
families in our
permanente
countries
en su hogar.
can have
Y el
permanent,
ingreso permanente
stable
no es el
income in
resultado
their
de
homes.
políticas de
And that is
ajuste,
not the result
sino que
of employment
ese
policies within our
ingreso
countries,
superior
but
hay
rather
que
the
darle
money
un
their families
reconocimiento
are earning abroad.
social, hay que crear incentivos para este
So
hogar y no
we need
generar
to
trabajo
create
más
incentives for
a
these
los que
families instead
están
of burdening
trabajando en
them
ese hogar.
with financing or funding something that should be the
Tenemos también
responsibility
ejemplos,
of our
por ejemplo, en México,
agencies and the nation state.
donde se han
Now, we
hecho
do have examples
programas
like Mexico where they've created
3x1, donde se
programs
utilizaba un
like the
porcentaje de
341
la
program,
renta
where a
inmigrante
percentage of the remittances
y se
sent
hacía
by
como un
immigrants
balancing de los
um,
fondos, tanto a
was
nivel
collected, and there was fund
del
matching
gobierno federal como del gobierno
by the
local
federal and local
para que
governments
se crearan inversiones de mayor peso para
to
todas las
create
poblaciones. Pero es bastante
larger investments
complejo
for all of the
este
population.
proceso.
Hay
But
diferentes
I know it's a
tipos
complex
de
issue.
remesas, ¿verdad?
Well, there are
Las
different
remesas
types of
son
remittances. That
lo que conocemos
341
como las
program
remesas comunitarias,
was
que
what they called
asociaciones
community
mexicanas
remittances,
de
where
México
associations of
para
Mexicans
desarrollar su
abroad
pueblo de
get
origen
organized
ponen un
to
capital
improve
estadounidense o
their
una
place of
alianza
origin.
con los
And then they
presupuestos de
create
crecimiento,
a
¿ya?
partnership with
Pero
the national governments
en
to
cuanto a la
provide
remesa individual, es otro
some budgets. But
planteamiento
individual
en general.
remittances are
Es un
something
tema de
completely
negociar
different.
mucho porque
And
bueno, hemos
this is something we could
experimentado
discuss in much
problemas
greater depth. For example, in El
de la
Salvador,
manera
we've
que
had an
son
interesting
escogidos
phenomenon.
los gobiernos en El Salvador.
During the two last
Mediante la
administrations in
renta
El
por impacto
Salvador,
social y aumentan el
to the
recurso
extent that
disponible
they
para las comunidades de origen de los migrantes. O sea,
increase
invierten en educación,
social
invierten en
on social
programas de
programs
salud.
such as
Entonces se puede
education and
flexibilizar
health,
un poco las remesas comunitarias
then
o
community
remesas acá.
remittances
Y
from
yo
these
creo que es un
associations
buen
of people
momento
abroad
para promover
start
algo que hizo
disappearing.
México, que
There
unía
was an initiative
simultáneamente
to do something
la
similar
remesa
to
comunitaria
what
y el
Mexico did
esfuerzo
to
nacional para ayudar a las
create
comunidades,
partnerships between
¿verdad? Y
these
ahora tenemos la
associations
remesa
abroad
individual y
and
la remesa
uh,
comunitaria. Ya, falta
the government.
decisión de
But
nuestro gobierno.
the government hasn't
La
taken
coordinación.
had the
Y
vision to
hablando
do
de
that,
remesas,
and so we have a lot more
como les
individual
decía, muchas
remittances
de
and
las
not so
familias
many community
dependen
remittances.
de esas
And as you
remesas
said, when it comes to
internacionales
remittances,
que están
a lot of these families,
en
these
turno
individuals,
de
depend
envío.
on their families abroad in the
¿Puede
United States or
ser
other countries
alguna disminución en el
for their
número
budget. Have you
de
seen a
las remesas que está
decrease
recibiendo
in the amount of
los
remittances
migrantes?
coming in to
Mira,
El Salvador
eh, cuando
from
se
migrants?
paralizan las economías
Look,
en países de
and
desarrollo como
the
Estados Unidos,
destination country
Canadá,
economies came to a halt, such as that of the
se
US
ven
and countries in Europe,
tanto los empresarios
the first
como sus empresas
measures
grandes
taken by
es empezar a
businessmen and
hacer
large companies
contratos
is to
laborales
start
informales.
releasing those people who
Y
were
lamentablemente estos
informally
contratos
working
informales
for
están
them.
caracterizados por
And these
conexiones
informal
con empresas,
contracts
personas migrantes
uh,
indocumentadas.
are usually
O sea,
with
los contratos
undocumented migrants.
estaban,
So the first
mira,
people to be let go. when economies slow down in these countries, the first people to be impacted are these undocumented migrants. And for example, in El Salvador, I think it's very similar throughout the region. 50% of remittances sent by relatives in countries such as the US to our country, 50% are undocumented migrant workers in those destination countries. So if the first to be let go and released were these undocumented workers, which does away with their income, then it has to have an impact on their families. According to statistics in El Salvador, 22% of all homes in El Salvador depend on remittances from relatives. So it has an impact. And this leads to something else I want to highlight. We need to be very careful with the data being published by Mexico and the region as far as an increase in remittances. In economy, in economics, rather, this is known as a negative growth. So it's still growing, but it's growing at a slower pace. So we shouldn't confuse the two because that will lead to an economic crisis, and we need to say it. It's the fact that these people don't have the same income or income at all right now will have an impact on the poorest of our families. So our governments need to start coming up with economic strategies to replace that dependence on family remittances and reactivate our own national economic machinery so that we are less dependent on those foreign remittances.
Tenemos también aquí un comentario de
Now,
los
we also have
participantes.
a comment from one of our
Nos
participants
comentan que El
who
Salvador ha
says
recibido
that El
bastante
Salvador
de
has
ayuda
received a lot of humanitarian aid from the United States, from USAID
medicamentos de que donaron
specifically,
250
where
ventiladores para
250 ventilators were donated to assist El
inyectar
Salvador with its
también en
national
los últimos
response.
20 años
It
Estados
also
Unidos
states that over the past 20 years, the United States has invested in El Salvador's health and long term development um,
incluyendo 111 millones
through more
de
than
dólares
2.6
en
billion in
ayuda por
assistance, including
no sé si
111 million for health alone.
algo
So
que
I don't
comentar
know if you
respecto
have
a esto
any
también llegará a
comment
los que
in
son
return.
migrantes retornados, qué es la
Does
población que ustedes manejan.
and does that funding reach the returned migrants, which is the population you serve? Well, I'll start out by saying that the healthcare budget for migrants is zero, 0 cents. There's nothing specifically for migrants. That's why I was saying that countries such as the US, and more than 90% of the patients we see are coming back from the United States. So the US should demand that that the funding they provide is used at least in part for returned deported migrants, whether it comes to their health or to get them access to employment. So
Ujú.
again, there's no
Ya.
specific
También
health budgets for
Paola
migrants.
Suárez, que muy
Now,
interesante
Paula
que
Suarez also states that it's a
estos
very
alivio
interesting project
del COVID en
and
las
asks
saturaciones de
what
clínicas
impacts
se han
COVID has had
gestionado
directly in the
apoyos
restructuring
disponibles
of
de
your
apoyos
clinic.
de
Have you
manera a
received new
fortalecer para
funding?
los retornados.
And what other areas do you need more support for to continue to help return migrants? Well, as I stated, we never closed our doors during the pandemic. Um, our clinic was open basically for emergencies. We started doing some virtual visits over the phone, visits for our patients. We also had a campaign where we would bring food and medication to our population. Now, the impact is that we needed to change how we did things. We need to go outside of the clinic. There were additional expenditures. And we got support from some organizations to be able to um, face that situation. And again, as I had said, what little treatment these migrants were receiving in the healthcare system were interrupted. First, because we no longer had public transportation in the country, and then some of the products um, were no longer available. And also the fear of traveling long distances to get medication with the risks that that would imply as far as contracting COVID-19 led to many people not wanting to do so. And that's why we had these two campaigns to provide
Muy buen
medication
trabajo y
and food.
ojalá puedan conseguir todavía
Um,
más
well,
apoyo para seguir con esta
great work, and I hope that you
campaña, por
will
favor.
continue to get more supports to expand your humanitarian
La
mission.
población retornada es
Um,
muy
providing
importante
care for our return
cuidarlos.
population is
Entonces,
hugely
todavía
important.
más
As I said before,
cuidados,
these
más
are people
cuidados
who a
y
lot of
más
times are
apoyo
more discriminated
para
against, more set aside, more
estamos
ignored.
ya cerca al
And
final
we are
de
now
nuestra sesión del
reaching
día de hoy.
close to
Quisiera
the end of our session
recordarle a todos los
today. I would like
participantes
to remind all
todas las
participants
grabaciones
that
y
all
todas las
of the
presentaciones
recordings
están
and
disponibles en el
presentations will
aula
be
virtual
uploaded
que
to the virtual
tienen acceso
classroom
y
that you already
nosotros
have
estamos
access to through
también
Canvas.
en esta aula virtual. Tienen
In
otros
that virtual
recursos
classroom, you will
también que
also
están
see other
enviando los
resources
ponentes
that
a los
were
cuales
provided
pueden
by our speakers
acudir y buscar y
to foster a
leer
discussion. You
para
can
conocer
download and
más
read them so
conocimiento sobre
that you
estos
can
temas.
further learn about these
Allí
topics.
también están los
There
foros
you
de
will also
discusión
see
para continuar
the
con las
discussion
conversaciones
forums
de ustedes, así que los
so that you
invito
can
a
continue the
que vayan
conversation amongst yourselves. So
a la
I
aula
invite
virtual
you to
y
visit the virtual
contesten todas
classroom
las
and
preguntas que
answer
nos han
the
colocado aquí
questions
todos los
that
ponentes
each of the
y
presenters
cualquier cosa
has
que ustedes
posed for all
necesiten
of you so
para
that
la
you can all
evaluación.
continue
Tenemos
with this
también
collaboration.
una evaluación
We also
permanente del
have
día de hoy.
an evaluation for today's
Está
session.
disponible en el chat
The
y
link
también
is now
la
available
pueden
on the chat.
tomar
However, you
vía
can
virtual para
also
nosotros
access it through the virtual
saber
classroom. And this is
su
important for
opinión
us to
sobre esta
know your
sesión.
opinion about
La
this session.
doctora Bojorges está todavía
And if Dr.
por aquí.
Bojorquez is still
Sí.
online, oh,
Bueno,
yes,
a
thank you.
nombre de los
So, on
organizadores,
behalf
muchísimas
of the
gracias por su
organizers of this
participación.
Summer Institute
Agradecerle
on Global Migration and
muchísimo su
Health, I want
participación,
to thank
por
Dr.
el
Bojorquez for her
excelente labor que
presentation
está haciendo
and
también en
thank her
México,
for the amazing work that
tratándole
she is
a
doing in
nosotros,
Mexico,
a lo que es
uh,
la
trying
situación que
to
viven los
further
migrantes
understand and bring to light
en cuanto a la
to
salud en
what
México.
migrants
También al
face
licenciado César
in
Ríos, a
Mexico,
quien
particularly when it
valoro
comes to health,
muchísimo su
and also Mr. Cesar
trabajo por
Rios
haber
and Dr.
participado el día de hoy.
Hisimosa
A
from El
todos
Salvador for
ustedes,
the presentation and
muchas
participation
gracias
today.
y les
And
recuerdo
to
que
all of
nuestra
you,
próxima
our
sesión será el
participants,
día
also
jueves
thank you very much. And I want to remind you that we have another session on
Muchas
Thursday
gracias a
with
todos y
very
muy
interesting
buenas
panelists. Thank you, everyone, and have a wonderful day.
Gracias.
Gracias.